Hi, my name's Jack Priddy, and I'm going to give you an e-lecture on biliary pathology, largely focusing on gallstones. So the learning objectives are going to be to describe the typical clinical features and underlying causes of common biliary pathologies, and to explain how you investigate and manage these. Hopefully this will be useful for your exams, but as someone who's just recently finished F1, I'm also aiming this at that sort of level, so hopefully this will be useful, particularly if any of you have any general surgery jobs on your in your first year of being a doctor. So we're going to look at the basic biliary anatomy. It's quite easy to learn, and once you've got your head around the anatomy, the rest of the kind of pathophysiology of various conditions will fall into place quite easily. We're going to look at how they present, different types of gallstone disease, and how you investigate this, and in particular what tests you order, and then how you react to the results that you will get back. So, quick bit of anatomy revision. We've got the liver that makes the bile, and the gallbladder that stores the bile. They're not labelled on the diagram, but the top parts are the green bit is obviously the biliary tree. The top parts are the intrahepatic ducts. These then form the right and left hepatic duct. These then both drain into the common hepatic duct. The cystic duct is the small duct between the gallbladder and the common bile duct. So the cystic duct joins the common hepatic duct to form the common bile duct, or the CBD. This is probably the most clinically relevant bit, or a lot of the tests you order will be looking at the CBD. The pancreatic duct drains into this, and then it goes through the ampulla vata into the duodenum. Again, it's not on the diagram, but the sphincter of Oddi is the smooth muscle ring around the ampulla vata, which can relax and contract and controls flow of bile into the duodenum. A quick bit of revision of the physiology of how it works. Obviously, bile is produced by the liver and stored in the gallbladder. Generally, in Western populations, the stones are largely formed from cholesterol. This is because of poor diet and obesity a lot of the time. Rarer stones are called pigment stones, and these are formed from bilirubin or bile salts. Up to 20% of people in Western populations have gallstones, which are completely asymptomatic, which is worth remembering when sometimes you might incidentally see gallstones on a scan. Doesn't necessarily mean you need to do anything about them. So biliary colic is simply pain that arises from the gallbladder or cystic duct. Generally, this is because there are gallstones in the gallbladder, and the gallbladder is contracting onto them, and this causes the pain. So therefore it presents as an intermittent or colicky epigastric or right upper quadrant pain, generally brought on by eating, particularly fatty foods, because that's when you're trying to release bile to help break down the fatty food, and so this is when the gallbladder is contracting. It can also be associated with a little bit of nausea or vomiting. You wouldn't expect it to last very long, although it may come and go, and you would expect it to self-resolve. It's worth saying also that the stone could be just in the kind of neck of the cystic duct, and it's contracting onto that as well. On examination, you'd expect them to be in pain in the right upper quadrant or epigastrium. To be honest, it might have resolved sometimes by the time they actually get to you. So it is simply just pain. The risk factors are quite easy to remember. You can remember them as the 5 Fs. So the first F is for fair, so it's generally more common in Caucasian populations. People who are overweight are at higher risk, and that's because of the excess cholesterol. Females are generally more at risk. This is because of the increased levels of estrogen actually makes you produce more cholesterol. Likewise, people who are fertile, and by that it means people who have had previous pregnancies, because you've got a high level of estrogen, that just makes there's increasing cholesterol saturation in the bile, which means you're more likely to form stones, and there's more estrogen around in pregnancy. And 40s, because you're probably perimenopausal, so you've had lots of estrogen exposure over your life. You could also swap one of these with family history, I think, so you could call it the 6 Fs really. Okay, so looking at the investigations you'll order, most patients will just get a kind of standard set of bloods if this is in a hospital setting. You'd get full blood count, CRP, LFTs. You'd largely expect all of these to be normal. Because they're probably presenting with epigastric pain, they should get an amylase as well to rule out pancreatitis. This would also be normal. On the right, you can see a picture of an abdominal ultrasound. The arrow is pointing to some gallstones sitting within it. Other findings on an abdominal ultrasound, there might be a little bit of gallbladder sludge. This just kind of is like the starting to form gallstones, but you probably wouldn't see too much else. Other investigations you could consider, if they're in a lot of pain, they might just get an erect chest x-ray just to rule out pneumoperitoneum, which would indicate perforation. Okay, so how to manage these patients? It's largely just simple analgesia, lifestyle advice, so if they have a low fat diet, they're less likely to develop more gallstones and more problems. Once people have experienced symptoms from the gallbladder, i.e. biliary colic, 50% will go on to experience it again at some point, and they're also at risk of complications of the gallstones, such as cholecystitis, which we'll just move on to in a second. Therefore, most of these people will at some point end up getting a laparoscopic cholecystectomy where the gallbladder is removed, therefore, in theory, solving the problem. So, cholecystitis. So this is when there's actual inflammation of the gallbladder, and this is usually due to infection. So how does this present? Again, it would be right upper quadrant pain, but it's going to go on, it's going to be prolonged now, because it's not a colicky pain that comes and goes, although there will be bouts of it. Because the gallbladder is constantly inflamed, it's more likely to be constant pain. Because there's infection, there'll be fevers potentially, and again, there might be some nausea and vomiting. On examination, you'd expect the right upper quadrant to be tender, and they might be something called Murphy's positive. So this is what you do on clinical examination. Murphy's sign is positive when there is a halt in inspiration due to pain, and this indicates an inflamed gallbladder. And the way it works is when you press on the right upper quadrant, ask the patient to take a deep breath in. This will push the gallbladder down because of the lungs expanding and the diaphragm coming down, and the gallbladder should touch your hand, and you'd expect them to say ow and probably stop breathing in at that point. A true positive test you should really repeat on the left hand side, and there shouldn't be a problem because obviously there's no inflamed gallbladder there. It's worth saying how does it come about? Can be because of gallstones most of the time. Can also be something called acalculous cholecystitis. This is more common in diabetics, and it's just because they've developed an inflammation or infection in the gallbladder, not as a result of the trauma of contracting onto gallstones. It's actually just because they've got usually poorly controlled diabetes. And obviously the high level sugars make them at higher risk of bacteria can grow in it. Okay, so investigations. So you might see signs of infection on the bloods, i.e. a rise in white cells and CRP. The LFTs you would expect to be normal, because at this point the gallstone isn't obstructing the biliary tree. There's not any kind of backlog of bile, and that's what causes LFT derangement or an obstructive picture on LFTs, which we'll go into a bit later. Again, amylase would be normal. Abdominal ultrasound, you might see a bit of gallbladder wall thickening, indicating inflammation, and you might also see a little bit of fluid or pericholecystic fluid, so just fluid outside of the gallbladder. And again, this is just a sign of inflammation. Again, you would consider things like an erect chest x-ray, maybe some urinalysis. Some of these patients might come in with almost right flank pain, so it might be difficult to distinguish from renal colic. So, as with all patients, you'd manage them in an A, B, C, D, E fashion. Some of these can present quite ill, they could even be septic, so you might need to resuscitate them with fluids. Then the mainstay of treatment is going to be analgesia, antibiotics. These don't necessarily have to be intravenous, it could be oral. Generally this would be coamoxiclav, and they'd be given at some point a laparoscopic cholecystectomy. So a hot cholecystectomy simply means that the gallbladder is taken out whilst it's inflamed. So generally it would be the admission, they've come into hospital. This is obviously ideal for the patient because you're getting rid of the gallbladder immediately, but it's a much technically more challenging operation and therefore has slightly higher rate of complications. So frequently what happens is the patient is treated with antibiotics, you wait for the infection and inflammation to die down, and then 6 weeks later or so they get an elective cholecystectomy when it's taken out, and it's a bit of an easier operation. However, obviously there's a risk of further complications developing if you wait and it doesn't resolve with antibiotics. So for some of those people where it doesn't resolve with antibiotics, or they might be considered unfit for surgery, however it's causing them a lot of problems, something called a cholecystostomy can put in into the gallbladder, and this is just a percutaneous drain. I wouldn't worry too much about that though for your exams. So I'm now going to just make a distinction between choledocholithiasis and cholangitis. So choledocholithiasis simply means there's a stone in the CBD, the common bile duct. This is causing an obstruction. Cholangitis, however, means there's infection in the CBD. These patients can be very unwell and will generally present as sepsis. And we'll go on to cholangitis, but just choledocholithiasis, because this is something that commonly happens to inpatients who have come in with cholecystitis or biliary colic. So this means on an ultrasound scan you would see a dilated common bile duct because the stone's causing the obstruction, so there's a backlog. You then see an obstructive picture on the LFTs, so this means there's a high bilirubin and ALP. So that's what we mean by an obstructive picture. A hepatitic picture would be a rise in the transaminases, so the ALT, AST. And then you can get a mixed picture, of course. So the main risk of choledocholithiasis is that this can progress to cholangitis. You've got kind of static fluid in there, which is never good. So that's the main risk. An MRCP might be done. This confirms the stone location more accurately. And then generally, once they've had an MRCP, these patients would then receive an ERCP. So MRCP, is a MRI looking particularly at the biliary tree, whereas an ERCP is an endoscopic retrograde cholangiopancreatography. So it's a camera that goes down, and then it's both diagnostic because you can see the stone. It's also therapeutic because they can remove the stone during it. However, these patients might just spontaneously pass the stone. So going on to cholangitis a little bit more, it presents as Charcot's triad, which is right upper quadrant pain, fever, and jaundice. And as I said, these patients can be really quite ill. Risk factors are being over 50, having known gallstones. However, cholangitis can be caused by other things, not just gallstones. So it could be a stricture of the biliary tree, this could be benign or malignant, or it could be something obstructing from outside, something extrinsic. Also, some people might have had a cholecystectomy, and during the operation there might be some slight damage to the biliary tree, and this can cause, again, kind of narrowing of it and can lead to cholangitis. So it's not always caused by gallstones, but the diagram on the right just show that it can give you a picture of where the gallstone would be. So, investigations and management. You would see signs of infection on the bloods, the full blood count, and CRP and LFTs would be high. LFTs, again, as I said, high bilirubin, ALP, maybe a rise in the transaminases as well, and this is just, it's largely an obstructive picture. You'd measure these as a septic you'd manage these as a septic patient, so they'd likely get a gas for a lactate, and you'd probably see a metabolic acidosis on the gas. And blood cultures where you would probably most likely see gram-negative bacteria, such as E. coli or Klebsiella. And then work up the management. You do ultrasound abdomen. Here you would expect to see a dilated common bile duct. Generally with cholangitis, these people will need an urgent ERCP, whereas choledocholithiasis doesn't necessarily need to be done urgently. This is both kind of investigative and management, because you can see the stone and you can remove the stone at the same time. But sometimes these patients will also get the MRCP, the MRI. So we've kind of already talked about the management a bit here, but again, they would need to be resuscitated. So you'd manage them A, B, C, D, E, as you should all your patients. They will likely need IV antibiotics and strong analgesia. and the ERCP for urgent biliary decompression. And how the ERCP works is they can see the stone, sometimes they can take it out. As I said, it might not be stones, so they can put stents in, and they sometimes do a sphincterotomy where they cut the sphincter of Oddi, which will just release the bile and decompress it. Further down the line, depends what the cause of the cholangitis was, but they may benefit from a cholecystectomy, and if it was something like primary sclerosing cholangitis, they could do with follow-up from a hepatologist. Okay, so we've talked about biliary colic versus cholecystitis versus choledocholitis versus cholangitis. I think if you take anything away from this, it's just this different distinction of what those four things are. So biliary colic is just pain, cholecystitis is inflammation of the gallbladder, cholecodolithiasis is a gallstone in the CBD, the common bile duct, which is causing obstruction, whereas cholangitis is infection in the common bile duct. Hopefully, as you kind of know how some of the blood results might look, and the difference between an obstructive and hepatic picture on LFTs, and hopefully it's cleared up some of the investigations and management that you'll be ordering. Okay, thank you very much.